Okay, ladies and gentlemen, are we going to make a start? Is there a vicar in the house?
Right, just a few housekeeping things before we start the meeting. And plus to say from St Mary's, a very warm welcome to everyone, and we're so pleased that this meeting is being held here because the church is here for the community's use. So if you have any events, then please do come to us. Right, first of all, ladies' toilets are in the back corner there, if anybody needs them, the right-hand side, where I'm facing. Men's toilets are in the porch as you come in, the door's in there. Fire escapes, we have a fire escape out of the ladies' toilets, a fire escape out of the kitchen down in this corner, fire escape out of this door here, the Sen House door, and also through the vestries in the case of fire. But we're not going to have one, but I have to tell you. Okay, thank you.
Thank you very much, and thank you to everybody for coming out. My name's Andy Mills. I'm an independent chair. I work for an organisation called the Consultation Institute. It's an organisation that works with public bodies like the NHS, local authorities and utility companies, and helps them with their consultation processes, how they ensure that people who use their services have a say in how services are planned and redesigned. So we're working with a number of bits of the success regime and the CCG, but my role today is to act as an independent chair to make sure that your questions are answered by the panel and that the panel get an opportunity to explain some of the thinking behind the redesign that is in front of you at the moment. Just a tiny bit more about me and kind of where I come from. I've been in public service for ages, that's why I kind of look old and haggard. I've been worked in the NHS, I've worked in local authorities, I've worked in education, I've worked in the voluntary sector. But perhaps more relevantly, I've also been a community activist, and I'm still a community activist. I've chaired my community association in my hometown for 3 years. So I kind of know what it's like also to try and advocate around getting the best for the people who kind of live in my area as well. So I'm hoping I'll bring those kind of skills to make sure that you get a fair say tonight. We've done the housekeeping, but the only other thing I would point out is that you can see I'm using a microphone. The reason for that is actually we've got quite a big audience today, and it's necessary to kind of project our voices so you can all hear us. But this is also the way in which the proceedings are being recorded, and they're being recorded so that the sound files can be put on the website, and people who can't attend tonight have a way in which they can access the proceedings. What that does mean, if you're going to ask a question, if you wouldn't mind speaking into the microphone and waiting till the microphone comes to you in order that your question can be captured properly. If you want to say who you are when you ask a question, that's great. If you don't want to say who you are, or if indeed you represent somebody, that's fine too. So on that basis, I think I'm just going to ask the panel to introduce themselves to you. Then we're going to have a short presentation that John's going to take us through, and then I'll take us into questions. And I think what I'll do, given the number of people that we've got here, I'll ask questions in threes, if that's all right, and then we'll see how the time goes, and as I say, we'll get through as many kind of sets of three as we can. Is everybody okay with that? So can I ask the panel to introduce themselves, starting on the left?
Is that working? Hello, good evening, everybody. I'm Christina Concar, I'm the Associate Director of Midwifery. So I cover the whole trust, everything, Carlisle, Whitehaven, Penrith, and everything in between. I've also been in the health profession of a nurse and a midwife. 1980 I go back, so I've seen quite a lot of changes here and overseas. And yeah, thank you for all coming, and I'll do my best to answer your questions.
So my name's Rod Harpin. I'm a medical doctor working in anaesthesia and intensive care, and also the medical director for the trust. Unfortunately, I go back a few more years than Christina.
My name's John Howarth. I'm a GP. I was a GP for over 20 years in Cockermouth, and I'm the Deputy Chief Executive of Cumbria Partnership Foundation Trust. So I'm the youngest of this group, actually. Not by much, unfortunately. Our trust runs the community hospitals, all community services in Cumbria. So I'll be able to answer anything around the Maryport hospital issues, and I'm going to do the overall presentation today.
Okay, I think some of you might have been to some of the other public events that we've had, and you will have realised that we've also had somebody on the panel from the Ambulance Trust and from the Clinical Commissioning Group. The Ambulance Trust representative tonight was due to come, but she's had a family emergency that she's had to attend to, but we are still expecting a representative to come from the Clinical Commissioning Group, who's just slightly delayed. So as soon as he comes, I'll introduce him, and he'll come up here, and he'll be part of the panel. Okay. Can I just check one thing? How many people have had an opportunity to look at the consultation document? Have you all? And if you haven't, there are lots of copies at the back of the room. So if you would like to take one before you go, and we're going to be referring to this, I'm sure, as we go through today, it'll be useful for you to be able to pick one up at the end of the evening. So thanks very much. John.
Okay. Well, thanks, everybody, for coming out tonight. And I was trying to think the last time I spoke in a church with as many people, and it was actually in 2007 when there were plans to close the community hospitals at that time, and I spoke in a church in Cockermouth, which was full like this. I'm going to, as I say, I'm a GP by background, but I work for the Partnership Trust, and I have colleagues from our acute trust who can answer questions on some of the different pathway changes in the acute trust, and I can catch most of the questions around anything else around the community trust. We have a new medical school that's been created in Whitehaven, a campus, and it's very exciting. I'm one of the two new professors. I'm Professor of Primary Care at the medical school now as well. So I've worked all my career here. I did my first job in West Cumberland Hospital. I've had 4 children there. I don't live very far away. So I'm going to take you through. So I'm going to be here when everybody else has gone. And no disrespect to many of my colleagues who come in for the consultation period and so on. So I'm going to take you through. I'm going to try and explain the different elements of the whole consultation. So the success regime, just to remind everybody, the success regime is a national intervention. It's a national intervention to our health economy in North Cumbria, West, North and East Cumbria. And it's brought all partners together. It brings everybody from the health sector into the success regime. And we have very significant problems in the health sector in North Cumbria, as you will have read, but there are major recruitment issues, some financial issues. Now, Success Regime was tasked to create a clinical strategy and a business case. So the clinical strategy, some elements of that are what we're going to talk about in this presentation. There's quite a lot of other stuff that isn't, for me, it's more important, some of the stuff we're doing outside in communities, working outside of the hospital, the main hospital. So I'll take you through some of the key elements of what, I don't know whether our technical expert is here.
Just while we're waiting for the technical wizardry, I think we've got Stephen from the Clinical Commissioning Group has now arrived. So if we can ask him to come up and he can introduce himself if he's going to say anything more than I've just said. We're going to be a bit tight up here, so...
Good evening, everyone. I'm sorry I'm late. I've been with our GP colleagues for the latter part of the afternoon in Wigton. My name's Stephen Childs, and I'm the Chief Executive of NHS Cumbria Clinical Commissioning Group, and we are responsible for carrying out the consultation process, which you are now a part of. Thank you.
So the consultation process, so the success regime has been around for about a year. There's been a whole load of workshops, lots of people have been involved in different groups, but it entered a formal phase, a legal phase called the consultation 2.5 weeks ago, I think now. And that's a plan, that's a 12-week period. If you're going to make major changes to anything in the health system, you have to go through a consultation with the public. And it's a 12-week period that will end in mid-December. And it's really important that we get, the consultation is a genuine consultation. In other words, that the opinions and views of the local people are fed in. We'll perhaps touch on this later. We've been in quite a lot of work with groups in Maryport to try and work together as a genuine consultation. So there's a proposal, but we have been working, we had a workshop all afternoon to try and see, well, can we do better than what's proposed, and can we come up with any alternative ideas? So the health services splits into people who provide services. I work in that side. People who commission services. So this consultation is led by the commissioners, the Cumbria CCG, Clinical Commissioning Group, and the consultation will go till mid-December. Then between December and probably mid to late spring, there'll be an analysis of all the feedback. So everything that's fed back, so it's really important if people have strongly held views that they actually feed it back formally into this process. Everything that fed back will be analysed. I think the plan to bring an independent expert in, isn't there, Stephen, to do the analysis and to make sure that every view is represented. Usually when there's a technical problem, it's my fault, which I've learned over several years. So lots of people don't believe this, but there cannot be any decisions made until the consultation period has finished. And there's a legal obligation to take into account the views put back from the public into this. So in spring, there will be an analysis by the local clinical leaders led by the success regime and the CCG to come to some decisions on the different things that are being consulted. It's not a vote, but many of us genuinely believe it's as important to listen to the local experts who've lived here and lived their lives here as it is to the clinical experts who it's a meeting of expertise, this, and that's, for me, that if we do that properly, it'll be a true consultation. So we've got major issues with our health. So here in Maryport, I don't have to tell many of the people who live here, there's very, very significant health challenges. There's real public health challenges. Many of the diseases, almost every disease factor, cancer, heart disease, is higher in Maryport than it is in the rest of England. We've got real problems. The recruitment crisis that's going on across the health system nationally is being felt very, very strongly here in Cumbria. So if you go across general practice, if you go to Copeland, 1 in 4 GP posts are vacant. If you go across our acute trust colleagues, real significant problems in attracting doctors, both in Carlisle and West Cumberland. My trust faces serious recruitment problems. So as a snapshot in our community hospitals, I was a clinical lead for the community hospitals for many years, and I worked in one as a doctor for over 20 years. As a snapshot in August, our vacancy rate for qualified nurses, so that's RGN nurses in community hospitals, was 39%, sorry, across all our community hospitals in August. In Maryport, it was higher. In Cockermouth, it was higher. We've got pockets of really quite difficult recruitment issues. The health economy, this is a real cheerful slide. The health economy is £70 million overspent this year. Whilst many things are improving and many people working genuinely very hard to improve things, we still have significant problems in delivering consistent quality in some of the services. So these are the challenges. And one of the things that we've said in my trust is that actually we've got to be very careful. If we keep consulting on things, the uncertainty that comes with that makes it more and more difficult to recruit. So we need to get through this consultation, get into, for my personal view, is we need to start rebuilding the health economy in North Cumbria. And there's some really good things happening alongside the challenges. What we really want to do, and what we should be doing, because we live in a sort of fairly remote and rural area, pockets of population, but really quite, long ways from anywhere. I do my clinical work in Millham now, and it's a long, place like that, very long way from anywhere. So what we're really trying to do is to actually create a real centre of excellence around this remote, rural, dispersed communities. And it's quite an exciting idea, that, because if we can actually turn all of this around and get come to some sort of agreements on the clinical pathways and so on, we could have a fantastic health economy in Cumbria. 7, 8, 9 years ago, people came from around the world to visit some of the things that we were doing in Cumbria. They came from Kaiser Permanente, this big organisation, came to, I think they came to Maryport and Cockermouth to visit us, look at some of the really exciting things that we were doing in integrated care. Maryport and Cockermouth were together national pilots for joined-up care about 2008-9. I wrote the bid for it with Dr. Money, and we went a long way to really getting things joined up locally, and things have stalled since. It's been quite frustrating. Now, integrated care communities are really the big idea in the success regime. It doesn't feature, a lot of the contention has been around stroke pathways and maternity and so on. Integrated care communities are our sort of building block of bringing more care locally, of actually shifting the care back. In the work we've been doing with Save Our Beds group and other groups and the practice and local partners, we've been mapping and modelling how much movement people have to do out of the town. So if you're in Maryport, 26% of households don't have a car. If you go to Urenrig, it's 46% of people don't have a car. So the travel times don't mean much if they're actually modelled on a car travel. You've got to have real travel time. There's nearly 30,000, it's 29,526 journeys every year. So nearly 30,000 journeys every year out of the town for care. Almost all of that goes to the acute trust, so either to Whitehaven or Carlisle. So 30,000 journeys every year. So a huge amount of movement. That's over 1 million miles of travel. So the integrated care community idea is to actually working with health, social care, all partners in health, with social care, working with the local communities and the different groups. You've got some great initiatives, the Urenrig local trust, and some of the initiatives and the Make Maryport Smile initiative. Fantastic stuff in Maryport. So it's working together to bring more and more care back to avoid people moving. And we can do, there's a huge amount of those 30,000 journeys that could be done back here. So these are the contentious changes. I'll take you through them and explain some of them, and then we've got questions. As I say, we have acute trust colleagues and CCG colleagues here as well. So most of the changes impact more on West Cumberland Hospital. So there was again, group of workshops, a whole load of long lists of options, and then a short list of options. And the short list of options for these are put into the document. And then in each of these areas, there's a preferred option. So the success regime is saying, this is what we are proposing of these different options. In the back of this, there are documents and ability to feed back formally and put people's view, your view back in. So in children's services, there was a spectrum of discussions ranging from all children's care being done in Carlisle to trying to keep inpatients, so trying to keep children's beds in Cumberland Infirmary and West Cumberland Hospital. Now, the preferred option is to do that, to keep some children's beds at West Cumberland Hospital. But within that model, what they will be doing is taking really sick children into Carlisle, because around what you need for really sick children is access to some services, some tests, some scans, and so on that might not be running 24/7 in Whitehaven. So that's the preferred option for children's services. For maternity services, and this is probably the most contentious of, well, the community hospital is very contentious, I know, but with maternity service, very, very contentious. And I think it's fair to say it's split the clinical community. There's been huge amount of work on this, different reviews, different specialist groups come in, and there are three options set out in the consultation document. Consultant-led maternity at both Carlisle and Whitehaven, a midwife-led unit, so that's what they call a standalone midwifery unit, so a midwife unit standing on its own in West Cumberland Hospital, and the third option of all deliveries, including midwifery deliveries, being done in Carlisle. The preferred option in the success regime in the consultation is for a midwife-led unit at West Cumberland Hospital. Community hospital inpatient beds. Again, there were a long list of options, lots of steps in the processes, considering the buildings, the staffing, and so on. And the preferred option in community hospital beds were to consolidate down onto 6 sites, which would mean not the closure of the hospitals, but beds being removed in Maryport, Wigton, and Alston. Now, I can explain a little bit later some of the work we're doing together on a counter proposal to that, and which is some quite exciting ideas emerging on that. But the formal consultation document is consulting on those things, and what we might hear a little bit about some of the work we're doing, and you can then perhaps feed back what you think about that as to whether that's something we should be encouraging the success regime to embrace as a final option. We're doing similar work in Alston and Wigton. A number of my colleagues and myself and our chief exec have been around multiple times to meet leagues of friends, local groups, practices, to try and see if we can find a real exciting future for our community hospitals in these 3 places. So I can expand on that in the questions if you'd like. Most of us who've lived and worked here for a long time cannot imagine a scenario. Now, I'm perhaps not being impartial here, but we cannot imagine a scenario without an A&E at West Cumberland Hospital. And so the preferred option in the success regime is to have a 24-hour A&E at West Cumberland Hospital and Cumberland Infirmary, and also continuing with acute medical care at both sites, with more innovative staffing modelling at West Cumberland Hospital, close partnership with the university as well, working on that, and older people's care and outpatient care being done at both hospitals. Hyperacute stroke services. Hyperacute stroke. Hyperacute means the first bit of after having a stroke, not the rehabilitation and so on and so forth. So hyperacute stroke is a real the first few days of treatment in particular, and it's changed. The thinking on this, when I first became a GP, we used to just manage most people with strokes at home, many people with strokes at home. We even used to manage heart attacks at home because that was how long ago it was. But what you have now are clot-busting drugs for strokes, and you have to have around that. If you need a clot-busting drug, you also need a scan, and you need specialist scans 24/7, so 24 hours a day, 7 days a week, Christmas Day, and the proposal here is to concentrate that at Carlisle. Now, again, some slightly contentious, but even people, if you put all the resources around stroke for those first few days together, you get better outcomes for not just those who need the clot-busting drug, but for those who don't as well. So if you've had a stroke and you go through a specialist unit that's got all the specialist staff and specialist consultants, all the investigations, you do better. There's loads of evidence for that now, but it does mean not so much for Maryport, Cockermouth, this area, but if you go to South Copeland and so on, it becomes more and more challenging to travel for these things or to visit relatives. So I touched on this before. The finances have never been great in North Cumbria. I've worked in some leadership position for 20 odd years now, and I can't remember any time when we were breaking even, to be honest. But it's particularly difficult now, and the challenges that triggered, if we remember the proposed changes to the community hospitals 2007 or 8, when they were marches in the streets and so on, the financial situation then that triggered those was nothing like. It was a tiny fraction of the financial challenges that we've got now. Again, I think we paid for this analysis to model it forwards another 5 years to say that we were going to be 163 million pounds in debt if we didn't do anything. So it's 70 million pounds every year. Most of that extra cost is because we're admitting too many people to the main acute hospitals. So there's lots of proposals one of the requirements of the national team was that we actually gave a plan till 2020 to close that gap. Very, very, very challenging, especially as social care partners are very challenged financially as well. But having said that, if we get through and we find a way through the success regime, there is a business case behind it that has gone to the centre nationally to request for very, very significant transitional support to the health economy between now and 2020. So most of the savings will come from efficiencies and cost reductions. My trust and acute trust colleagues will be the same. We've been taking 2, 3, 4% out of our costs every year for about 5 years now. So it's not that we've been having increasing money, we've been taking costs out. The whole health system, the idea that NHS is protected from the austerity measures doesn't play out on the front line at all. So most of the plans to close the gap is to become more efficient and by working together better and so on. Some of the ideas are around, big ideas is how much care can we deliver locally rather than sending it through to the hospital. If you go to a hospital, it's very, very expensive. Everything, even if you go by ambulance, it's hundreds of pounds for a round trip by ambulance. So, and if you look at Maryport, we've done a little bit of work on this over the last couple of weeks. If you look at Maryport, more than half the money, if you had a Maryport pound, more than half of that pound leaves and it goes with the 30,000 people who are moving. So one of the ideas, and again, we need to do this in partnership with specialist colleagues and together, is to shift a lot more care back and stop people having to move so much for care. The actual changes, the pathway changes in this document do save a small amount of money. So when Sir Neil McKay stands on platforms and says that it's not particularly about the money on these platforms, well, it is to a certain extent. There's a small amount of money to be saved by doing some of these pathway changes. But most of the contentious stuff in here will go nowhere near. It won't even scratch the surface of closing that gap that we've got. It's the other things that will do, the efficiency and the much more integrated care. So there's an awful lot. If you, as I say, I did my first job in the NHS in West Cumberland Hospital. If you actually, we've got a brand new, fantastic facility, and an awful lot of. So some stuff needs to move. If you ask my personal opinion, some things need to move for medical reasons, but there's an awful lot more that doesn't need to move for medical reasons. And there is a very clear plans to bring a lot of that back to West Cumberland Hospital. So there's a lot of the surgery that's been moved, acute surgery planning to return, some less serious trauma surgery being managed there, significantly more planned surgery because there's been a large number of people moving from West Cumbria up to Carlisle for normal operations that could be planned anywhere. So there's a plan to bring in quite a lot of that, more diagnostic. And so overall, in these plans, the plan is to actually try and make the new West Cumberland Hospital really pay for itself by bringing a lot more of these, perhaps less urgent and emergency things back, but stopping a lot of people travelling for care. So, I say it was my job to try and take people through all of these. We all have our views on these different different pathway changes and so on. What I would say is that even that there's a lot of people been involved in. And these are incredibly complex, difficult things. The maternity issue at Whitehaven is a really difficult. I understand all the arguments, and I have my own views on it, but all the arguments on every side are genuinely held. So, but there, as I say, the decisions haven't been made, and I personally believe there is genuine opportunity to feed back into this and influence some of the decisions, and there's a legal obligation on behalf of us who are in the success regime, local partners in the success regime, and the national team that have come in. There's a legal obligation to take that feedback into account in making decisions. So I think we're going to pass it for questions now.
Okay. Conscious that we're quite cramped up here, and I'm considering getting out the way so that you can get a better view of the panel. Would that be okay with you? So I'm going to go and stand over here. John, is that all right with you? Swap places? Oh, yeah. So, do folk have some prepared questions? Are there anything immediately that people would like to ask? So I'm going to, if you could raise your hand, and I'll pick out three of you. There's a gentleman there. There's a gentleman here. Was there a third question? And a lady there. So if we could start with yourself, and we'll come to yourself, and then yourself.
Thank you for the opportunity to talk. I won't give you my name. I'll give you my date of birth. 7th of July, 1948. I was born. And when my mother went to pay for my delivery, the matron said, no charge. So I was the first national health baby in this area. And it's sad to say, although it was the pride of the country, the best in the world, we've seen it deteriorating. The question I want to ask is, the figures which you've put on the board, on the screen, you've put them as being gospel. I question them. The truth is, the National Health Service is not overspending, it is under-resourced grossly. That is point one. And what I feel strongly is, if you tell a lie enough, people will believe it. A second point you made was about local recruitment. We recognise now that the money which was spent on Carlisle Infirmary, quite rightly, should have been spent on services in the West, in our own community, which for those of you who don't know, particularly the lady there who's involved with the maternity, yes, it may be a round trip, of 100 miles from Whitehaven to Carlisle, you're forgetting about Millham, you're forgetting about Eskdale. Whitehaven is bang in the middle of it, and it's bang in the middle of our working class community, which is West Cumberland. Is that right, or is that wrong?
Okay. Okay, thank you. I think the gentleman here. Tom, is it easy for you to go that way and get to this gentleman here first? Sorry, Tom, just here.
Thank you, Mr. Chairman. My name is Bill Barnes. I'm chairman of SOB, the campaign to save our beds. And we had a meeting like this 6 months ago, and that 6 months hasn't been idle. And what I want to ask, a simple question of the panel: what's your interpretation of the word consultation in the context of tonight's meeting? Because 6 months ago, you submitted an interim report to the CQC, and it contained a recommendation to take the inpatient beds away from Maryport. That released an explosion of opposition throughout the public. In the 6 months since, you've had 7,000 signatures to a petition opposing the proposal, 400 letters, dozens of emails and letters sent separately. And at this point, I have to say that I don't know one single person who's had a reply to a complaint. Not one. They've had a standard acknowledgement, and the town of Maryport got an acknowledgement in the press, but nobody, not one letter, and many of them come from 6-year-olds, have had a constructive reply to their problem or their concern. You've also had support letters from the League of Friends, Maryport Rotary Club, Deering Parish Council, the Love Maryport team, massive publicity in all the local papers and on TV stations. We had the support of Sue Eamon MP, who's raised problems with Sir Neil McKay, and now the council recently passed a vote of no confidence. Now that's consultation, I would have said. And yet, this document, guess what it recommends? Take away the beds from Maryport Hospital. So what's the value of this consultation in your eyes?
Thank you very much. And the final question at the back was the lady with the check top on.
I think I just need to introduce myself as Carney. Everybody else knows who I am. I think you get from the number of people here tonight how this community is enraged by your proposals. Totally enraged. And I don't believe that anybody wakened up in the morning and said, we're going to put some integrated care into Maryport. We're going to do this for them, we're going to do that. My question is, this is totally cash-driven. Can you deny it or agree with me? And the second question is, this integrated care that you're talking about so very well and so laudably, how has it been tested? It hasn't been tested and proved to be good. You've got 5 homes in West Cumbria that are going to go as a result of the government cuts. What next? We could lose this one next. I hope not. But this is another thing you haven't taken into consideration, that the local authority may have to cut down on elderly care. You've never talked about end of life care. This is all the things, but this is totally cash-driven. Can you deny, or will you agree with me?
Okay, shall we turn to the panel then? So there's a question from the gentleman about, this is about under-resourcing of the NHS. There's a question from the lady about this is being cash-driven. So can we start with that? Stephen, do you want to pick up on any of those questions? Cash-driven changes and the NHS is under-resourced, and don't keep talking about there's not enough money locally.
Yes, thank you. I'll make a start and then I'll hand over to John. So if I just take the issue of the NHS being under-resourced, I don't think there's anyone here on the platform or anyone in the audience that would deny that the NHS could easily consume a lot more funding. And The reality is, though, the situation that we have to manage is the resources at our disposal. And we have to try and make the services that you receive as safe as possible and of the highest quality within the budget that we're given to spend. And that is reality, much as we might like to join you in lobbying for more resources. We have to do the right thing by you with the budget that we have. And then on a related question, to address the issue of whether these changes are about saving money, I can honestly tell you that that is not the prime motive. The prime motive of the changes that are proposed and that we are consulting upon is about safe, high-quality services. There is undoubtedly still a financial challenge that we face. But to be honest, even if we were breaking even financially right now, we would have to address the issues of safety and quality of the services that we're talking to you about tonight.
I'll stand up. I'm going to be sort of slightly off message here because I think the NHS is under-resourced. And but the problem, I think, as Stephen said, is we're the local leaders here. So everybody sitting up here are the local people within the success regime. We are extremely challenged by the constraints on finances. I think Stephen was right in that the meetings I've been to, that's not been the primary drive, but there is, of course, a deficit we have to close, and but the most of the deficit. Well, there's several things. One is Cumbria doesn't get any real recognition for its rurality. So we deliver services across the geography of Cumbria, and the population density is 74 per square kilometre. If you go to, everyone who makes policy does it in places like Islington, where it's 18,600 people in every square kilometre. So we get similar money to if we worked in an urban environment over 20 square miles for the whole of 2,000 square miles for Cumbria. So it's very challenging to deliver health services. There's austerity everywhere in all sectors: health, education, public, social care, and we have to try and make the best of what we've got. There's lots of us lobby nationally, and every opportunity we have for more money. I'll just try and address the issue that Bill said about all the volume of stuff, and I've heard this in a number of meetings I've been around. There's been a huge amount of volume of information given to the success regime. It's touched a real nerve in communities, and there's thousands and thousands and thousands of pieces of information fed back. Now, I had it made clear to me that the stuff that's been sent, the letters you've written, Bill, all the emails and so on, will be part of the overall assessment of feedback, even though it's not within the. We've entered this funny thing, the legal phase of the consultation. But if you want my honest view, it's not the way. The way of actually making progress is to sit around the table and have proper conversations and really try and design things together. And the process that we've had has not necessarily done that. But we are doing it now, and we're trying very hard to design things together, particularly here, but also in Alston and Winton, to get a better proposal together. And that will be given to the success regime as a counter-proposal, and we're working on that. I worked all weekend on it. There's many other people been working very hard to contribute to it, to try and get really quite exciting plans for Maryport.
Could I ask Rod or Christina to pick up on the question about recruitment? I think the gentleman was asking about.
I can take that, yes. Recruitment, as I suppose medical director of the trust, and particularly with our shortage specialties, we spend a lot of time on recruitment. There's two aspects to that. You do need people to, well, two or three aspects. You do need people to perform the job. We are looking at some, actually, as far as the nation goes, some innovative staffing strategies, which involve non-medical staff trained up to essentially function as junior doctors. So first of all, we're not past innovation, and the traditional medical model is changing. So that's one thing to say. Two, however, you do need the specialists in the service, and there's no doubt there are some services which are both nationally and internationally in shortage, believe it or not, and one of those is pediatrics. We also need to recognize that, for instance, in the stroke situation, that stroke experts are also a rare commodity. So it sort of drives two factors. One is that we've been managing so far on a lot of locum doctors, and locum doctors not only cost more, but they don't provide the continuity of service largely and the improvements in services that we need to drive. So that's the locum situation. So we need to get to a point where we've removed uncertainty and we can recruit our own substantive staff. We focus some of those real shortage areas where they will have best impact, and we get past the perpetual problem we have across the trust, and in fact across the health sector. You heard John talk about 23% shortage of GPs. This is a problem across many of our medical specialties. And I'll take it outside of medicine, or the traditional doctor role. We're also short of other health practitioners. So we need to get to a point of certainty. We need to get past a point where we're paying a lot of money to try and prop our services up. And that's in part what some of the service reorganisation and reconfiguration is about.
Okay. John, I think you were asked a question about whether the integrated care model has been tested. Do you want to say something about that?
Okay. A gentleman mentioned Millom. That's where I do my clinical work now. And so the ideas we're coming up with for Maryport, but other areas, are based on quite a lot of good local evidence and also national and international evidence. So when we started, what people perhaps know some of the story around Millom. There was a march in the streets in May 2014 when we had to temporarily close the community hospital. The GPs couldn't recruit. They pulled out of covering the community hospitals. My trust tried to recruit, and we couldn't recruit a doctor to go and work in Millom. Hospital closed temporarily. 2,000 people marched in the streets. There were very difficult meetings. Afterwards, 350 people came, a meeting like this. And they were driving home from that. People came up to me during that meeting and they said, again and again and again, nobody listens to us in this community. You've stripped services out. The ambulance isn't here. And I drove home and I thought, you're right. Nobody really has listened to the community. And so at the follow-up meeting, we invited the community group, the protest group, and we created a thing called the Millom Alliance. And the Millom Alliance sat down with, I'm the Deputy Chief Executive of my trust, so I can bring people. I brought some senior people in, acute trust colleagues, which was Morecambe Bay down there, part of it. We went, and the community groups, the action group, and the League of Friends, and the general practice, and we sat around and we redesigned the whole services. And what we've done in the last 2 years, if the community did a recruitment video for us. The practice tried for 18 months, didn't recruit, had one reply to its advert, spent thousands and thousands of pounds. Community did a recruitment video, it won some national awards, recruited 3 doctors. It was the children doing a recruitment video. We did a huge number of other things, and we've cut down, we mapped how many people moved from Millom every year. It's 22,900. And 26,900. And we worked with the community and with all the local acute trust to reduce that movement. We cut 130,000 miles off the travel. We cut the emergency admissions by 23%. And we've done that in two years. Now, we've just created the Maryport Alliance. So it's the different partners, the people who have most invested, the passion that comes from the community. And we've had 3 meetings so far, sitting down to try and design something very rapidly together that models the same sort of things that we were doing down in Millham. Actually rethinking how we use the hospital, possibly keeping beds, but repurposing the beds, refocusing them around, shifting more and more care here, more around rehabilitation, reablement, which is a social care sort of approach to keeping people at home. Actually focusing it on reducing the use of beds in other bits of the system. There are 200 nursing and care home beds in Maryport, over 60 extra care beds, and a lot of money spent in all these things. So if we think of the whole thing, then we can imagine the community hospital being if we all come together and work in a different way, we can get a huge amount of stuff going on there. The 30,000 journeys, how many of those we can bring, we're beginning to map it now and understand it a lot better, how many of those we can bring back and do locally in Maryport Hospital. And really importantly, can we make it the hub of what we're calling it a population health system? In other words, the challenges that occur for health in Maryport, we don't spend anywhere near enough on the public health, the issues that population faces here. We spend all the money of people leaving the town to go for care, and we should be spending far more money in Newinrig and other wards around here, building the health of the population and improving the health. So we've got work in progress. And we've got a Maryport Alliance, and we've adopted Make Maryport Smile as our logo, which I think is fantastic, making Maryport smile, because it's positive and it's constructive. And it's that sort of approach that's going to deliver all the shifts of care and the change of money and all the rest of it. Just simply cutting beds out in isolation, where it's not, it would save minimum amounts of money anyway.
Okay. So. Obviously, the enthusiasm that's coming from John means that he's given you a very full answer. Perhaps ask him if we can shorten the answers a little bit so we can get some more questions in. So 3 more questions from anybody. There's a gentleman here, a lady here, and a lady there, and that gentleman there, and then I'll come to this side, okay? So starting at the front here and then going backwards.
Donald Layton from Maryport. The problem about the document is that as far as community hospitals go, it doesn't actually say very much of the sort of thing that John's just been saying, which I'm absolutely in favor of. I couldn't agree more that we should have as much care in the community as possible. But then to say, so we will take away the inpatient beds, is a total nonsense. They should be an integral part of care in the community. What is more, in this document on page 17, it says 3 particular areas especially deserve community hospitals. Those that are very remote, those that are very widespread area of rural population, those in the center of community. And then you produce 5 options, all of which say close Alston, the most remote, close Wigton, covering the widest area, close Maryport, where the hospital bang in the middle of one of the worst areas of deprivation of all. In other words, you produce in the document a series of options which are totally unacceptable. I'm delighted to hear that, though it's not in the document, now some sort of sense is beginning to prevail. But this means that the answers anybody gives to these documents, where you're asked to answer certain prescribed options, is worthless when the options are not options at all. Thank you.
Thank you. lady behind you.
My name's Kate Whitmarsh. I work for the Ewan Rig Local Trust. I've got two, hopefully, quick questions. One is, we've heard about the challenges that the NHS is facing, and we've heard that the success regime's approach has been to adopt a clinical strategy. This question is actually for the audience rather than for the panel. Personally, I don't want the answers to be provided by the success regime and through a clinical strategy. I want the answers to be provided by the experts in this room, and all of us here are experts, whether we're parents or elderly people needing care, GPs, etc., etc. So the question I have to the audience is, if you agree with me and you think the answers should be provided by people in this room, could you raise your hand if you would like to be involved in what John has just spoken about, which is this Maryport Health Alliance and a new recommendation, an alternative recommendation that we would like to put to the success regime?
Yep, good idea.
Thank you. And my second part of the question then is to the panel. Will the success regime commit to actually listening to that recommendation and taking it on board? Because as Bill says, we're a little bit cynical about what consultation means.
Okay, thank you. And the lady in the purple top in the middle.
Thank you. I'm Linda Radcliffe. I'm a member of the Town Council. I'm also a public governor for the NHS Trust. Could I just comment that the ICCs are nothing new. There's nothing new there at all. It's been done in the NHS before, where I worked for 35 years, under some other name, but it was done because all doctors, all community staff, everyone worked together for the good of the patient, and that was integrated care in its totality. But I would like to ask two questions, please, two main questions. It's been really clear that the success regime have struggled to understand the transport in this extensively rural county. It's quite different from urban areas where the other two success regimes have worked. Sparsity of the population, together with super-aging, will make it very difficult to deliver very good practice to all people if we are not very careful about what we do. We need to combine and remember that there are many single aging people living on their own. They will certainly need more input than family-orientated patients. Now we know for certain that social services cannot stand the strain now, never mind in the future. We are in trouble with our social services care. There is not enough. Public transport is more than a dream for many people. And large numbers, especially as we've heard, 46% in our Ewan Rig estate do not have cars. If we take all of the beds from this unit in Maryport, this means that if we keep the Workington beds, then people will have to go there. Who's going to pay the fares for those people who are on low income or no income so that they can actually get to visit their loved ones? And it is a medical fact that those people who are parted from loved ones, it makes an extra stress on their health, which can lead, in some instances, to an earlier demise. Winter weather can be harsh in Cumbria. Remember the floods? I'm sure you do. It's very fresh in my mind, as it will be in most of yours. We were unable to travel on our roads. Who's going to tell the maternity cases who have to be transported, sorry, love, we'll have to turn back. We've got nowhere to go, no roads to pass. Because it happens that all of the roads between Whitehaven and Carlisle do flood. All of them. But the last thing I want to say is, please remember that every one of us in this room and every one of us in this land are entitled to the same health care that was promised in 1948. Every one of us. And in that case, please remember, panel, that when you are making your deliberations, this county is not easy to travel. It is not easy to get around. It is not easy to get a job. It is not easy to do most of the things that town dwellers can do. Remember that, please. And please also remember that everyone here is worried not only for themselves, but for those we love and care for.
Okay, we've had quite a lot of kind of questions there. I'm going to put some of those to the panel, if I may. So there was a question about, I may boil this down too much, in which case you'll come back to me, but about the option development process. How did we get to those options because you feel they've not been correctly constructed? Are you comfortable with that? So if one of you could answer a question about how did we get to the options. I know there was a long list and a short list, etc. Then there was a question, which probably can go alongside that, which is about alternative models, and would the process enable those different models to be part of the consultation? And then the stuff about transport, which we'll come back to.
So thank you. I'll try and answer the first two questions. So around the options that aren't options and the challenge, if you like, to us about an alternative proposal. So perhaps the first thing I should do is just clarify what the role of the success regime has been and is from here on. I think we've been very fortunate to have had the resource to enable us to have this success regime, but it has been here not to tell us what to do. It has existed to try and facilitate health organisations to come together to think about what alternative solutions can be to meet the challenge of safety and quality of service that I mentioned earlier. So the success regime is not responsible for ensuring that there is a robust, effective, valid consultation. That is the responsibility of the Clinical Commissioning Group, which is why I'm here tonight. And the consultation itself is an opportunity to just hear people's concerns and listen very carefully to those concerns, to try and answer questions as best we can, particularly around the detail of the proposals and how we got to this point. But very, very importantly, it's also to receive alternative options, proposals, suggestions, because we don't pretend to have exhausted all of those options. That's a really important point. So the output of the consultation, when that's independently analysed, will be a presentation of those alternative proposals. And we would welcome that very, very seriously, and we will take them very, very seriously.
Okay, there was a question about transport, which I'm sure we're going to come back to. Rod or Christina or John, can one of you take that?
I can. Do you want to have a go, Rod?
Yeah. Well, I can speak to some. First of all, I do recognise the human aspect of needing to be near people at times, and that's not lost on us, and certainly from the point of view of the transport, then I suppose I deal with two extremes in a way, or the more extreme of transporting the critically ill and some of the patients who are extremely unwell from various sites, not just from Whitehaven, Carlisle, and we do move people across to Newcastle. It's a shame we haven't got one of the ambulance providers who couldn't make it tonight, because I think they need to tell their story as well. They are very organised as far as the logistics of moving people, in terms of the more extremes of conditions. And, you know, if those eventualities happen, then we deal with it as in essence, a major incident, and we organise ourselves around that, and we rely on them and other services as well, such as fire. So in that extreme situation, where the roads are completely impassable, then other systems kick in across the whole organisation of healthcare around this county. So, and just to say that from the public transport, a lot of thought was put in to, and I think it's an evolving piece of work, that really, if we are going to reorganise our services, we do need to consider the needs for the transport, not just of patients, their carers, their loved ones, but also actually our staff. And a lot of trusts that have done this, and a lot of health systems that have done this, have put in ways of moving people from A to B. So that's a work in progress. I think that the feedback you provide on that does help us focus our minds on it.
I think I may have missed a gentleman on this side. If we could go there, Tom. And then was there some questions on this side? There's a lady here, gentleman there, and two ladies at the back. So we'll come to you after this gentleman has asked his question.
Thank you. Maurice Tate, I'm the treasurer for my sins of the League of Friends, and the meeting that was held this afternoon has not given me the time to speak to my colleagues on the League of Friends before I say what I'm going to say. So with that proviso, I sincerely believe that the work that is now being put in by the Maryport Health Allowance will allow Maryport to keep the beds in its hospital. I trust John, and I have also had a long conversation with Claire, and I feel that together they will do their very best to protect the Maryport Health Services, specifically the hospital. I'd now like to change hats. I was born and bred in Carlisle, for which I'm very proud, but at the same time, I do appreciate that I've lived in West Cumbria for a lot of years. And I can look at the two hospitals, the two acutes that is, at Carlisle and the West, absolutely equally. My wife and I, on the occasions that we've had to, have used both of their services. And I'd now like to put a little suggestion regarding the geography of Cumbria to the success regime. Cumbria, as I'm sure we all know, is basically a diamond in shape. You can divide a diamond top to bottom and left to right. Carlisle is at the extreme top point of the diamond. Whitehaven is at the extreme western point of the diamond, but it is in the middle line. If we can only afford, and I'm prepared to go along with the financial calculations, that we can only afford one absolute centre of acute care for children care, stroke care, and even more important, maternity, then surely there can only be one place for that specialist hospital to cover the whole of the county fairly and equally, and that has to be Whitehaven and not Carlisle. Thank you very much.
Okay, can we take the kind of four questions up there, and then we'll if you keep your ears on the Whitehaven Hospital, please, question, and then but we'll go up this side of the room. The lady at the front here was the first one.
I'd like to ask a question related to the maternity unit at West Cumberland. I had a read through the consultation document, and the preferred option is for midwifery-led unit. It does state that there would be potentially up to 300 to 400 births from women who are low risk at the midwifery-led unit. I'm not quite sure I believe that, but that's what the consultation document is saying. So in that case, we are asking 800 plus women to travel, potentially in advanced labour, to Carlisle. Now, some of these women, as someone mentioned before, would be travelling from places like Whitehaven, Seascale and Millham. And do we think it's acceptable for a woman in labour who is classed as high risk because she can't deliver at the midwifery-led unit to be transported either by bus because they don't have a car, or by car, or an hour and a half's drive to Carlisle? Now, I don't personally think that is a viable option. And not only that, in asterisks underneath those figures, it did suggest that there would be a potential 100 extra births which could come from low-risk elective caesarean sections. Now, I thought a caesarean section was major surgery, and I would like to know what is classed as a low-risk elective caesarean section, and what midwifery-led units in the rest of this country would carry out a low-risk elective caesarean section with no consultant cover after 8 o'clock at night. Okay. Do we think that's acceptable? What happens if a woman had a hemorrhage after 8 o'clock at night?
Okay.
And someone also mentioned as well, for example, our roads aren't very good. We haven't got great transport. I know Mr. Harpen mentioned that we would then look at other ways around that. What are those other options then? If the roads are flooded, what else would we look at?
Okay, great. There's a gentleman at the back there, and then it was two ladies at the back. So the gentleman right over the far side. By the way, that lady was quite right to, this gentleman here is from the news station. I think it's entirely within your right to say you don't want to be on camera. So if anybody else feels the same way, I think he's taken public shots. But if you don't want your question featuring, quite right. Please.
Thank you. I'm going to give you two examples of why it is absolute folly to run a maternity facility down at Whitehaven if it isn't going to be 24/7 consultant-led. Over 2.5 years ago, my son and his wife, she was pregnant. At 25 weeks, she started to hemorrhage. She was admitted to Whitehaven. They thought they'd stabilised it. They kept her there overnight. 6 o'clock the following morning, she went into labour and gave birth to a stillborn little lad, beautifully formed at 25 weeks. They then had the harrowing thing of to go through a funeral. There isn't a week goes by that they're not along to the cemetery to see my grandson's grave, look after it. They were blessed. Over 15 months ago, they had a little girl. They then had to make the choice, do we go back to Whitehaven to go through the pregnancy again and delivery, where they couldn't guarantee a consultant there all the time. They took the decision, quite rightly, to have baby up at Carlisle, and I can well understand they were asked, well, why don't you want to come to Whitehaven? I think it was quite obvious why they didn't want to go to Whitehaven. Then we're not in a name blame or a blaming sort of issue with Whitehaven. Whitehaven did the best they could. The bereavement that the counselling they gave was amazing, but that is a reason why you cannot take the risk of having a maternity-led facility down there if it isn't going to be 24/7 covered. In addition to that, within the last 16 weeks, my daughter's son, 13-year-old, he'd had a bad throat for well over a week. On the Monday, my daughter actually rang up the Q doc somewhere around about 7 o'clock, gave them the diagnosis. She says, I think it's tonsillitis. They said, take him to your practice in Maryport. She rang there about 9 o'clock and they said, you're just going to have the Q. So she just put him in the car, took him to the A&E at Workington. They said he'd got tonsillitis. That was fine. 7:30 that night, he went in, he was in excruciating pain. She then dialed 999. Ambulance eventually came, an hour and a half afterwards. It wasn't a paramedic, they were just ambulance drivers, so they couldn't give him any pain relief. She was in the process of actually putting him in the car because she'd waited that long. Having rang Whitehaven, they said, don't bring him here because we've got no paediatric beds. Take him to Carlisle. The ambulance arrived that says, our instructions from the call centre is to take him to Whitehaven. The duly took him to Whitehaven. The A&E said, what have you brought him here? We haven't got any beds. Gave him a shot of morphine, took him up to Carlisle. And at 9:30 the following morning, they didn't deal with his tonsillitis. They took his appendix out. So I really have great concern of what is being delivered.
Okay.
That's all I'm going to say. Thank you.
I'm going to hold the two ladies at the back. I will come back to you in a second, but I think there's quite a lot we need to take on there, and we've gone on a kind of tangent here into maternity services, which I think is good. Can you guys pick up some of the questions around maternity, and then we'll come back to why not West Cumberland?
Okay, thanks. I'll pick up the maternity and the transport issue, and really the way I would tackle this is thinking, first of all, I think it's reasonable to make a clear statement that if we lived in a perfect world of full staffing, good quality, etc., the consultants across the trust would prefer to keep both units running. There's both consultant-led units running. So from the preferred clinical sort of view, that's the starting point. Now, the difficulty for us is that running these services, which are in a fairly fragile and difficult to sustain situation from a number of staffing issues, then we get into the situation, do we leave it as it is, where some days and nights we wonder if we've got the cover to keep it open, versus making some sustainable choices. And these are difficult choices, there's no doubt about it. So it's the risk of having the unit on, off, versus trying to propose something which would have sustainability. Now, you mentioned about the freestanding midwifery unit. I think the other half of the equation is to listen to our, head of midwifery and just sort of perhaps answer a bit of that question.
Yeah, we'll do, absolutely. Okay, I'd just like to answer your question. First of all, I'd like to answer the question not just as a midwife, but as a mother and a grandmother. My 4th grandchild's due in 2 weeks' time as well. And I've actually travelled in the back of an ambulance in labour with my first baby from a freestanding midwifery-led unit. So I know what it's like at the back of an ambulance as well, in labour, in advanced labour. So your question was the 300 to 400 births for a midwifery-led unit. Those figures came up with those around just looking at what an average is around percentage around midwifery-led unit births around the country. However, most freestanding midwifery-led units do start off with really quite low uptake of births, if we're honest, until people become more confident. So we're not quite sure how many births we would get at our freestanding midwifery-led unit at Whitehaven if that would be the case.
Hold on 1 second.
I was going to say,
sure we get your kind of follow-up.
I can hear you, but I don't know if everybody else can. This lady was asking about Penrith. They only had 51 last year. So Penrith births are very low.
Sorry, I was just responding saying I think Penrith only had about 40, but you said it was about 51, so yeah. I don't really know what the uptake of the midwifery-led unit would be at West Cumberland, because Penrith's been run for a very, very long time, and the women there don't seem to be wanting, well, not that they don't want to deliver a Penrith, but the numbers aren't fantastic. So that tells me, how viable is it going to be at West Cumberland when the consultant-led unit is going to be an hour away? What women are going to want to choose to go to a midwifery-led unit with a consultant-led unit so far away if anything does go wrong? And I can't remember the last time that the midwifery-led unit actually shut the doors to the public because there wasn't enough staff. And I know that the midwifery-led the consultant-led unit at West Cumberland has very good outcomes as well. We give very, very good care.
Okay.
I'd just like to acknowledge that as well, because I work across all the areas, and I was at West Cumberland yesterday. We're very proud of West Cumberland, very proud of the midwifery, and very proud of the outcomes. There was something I was just going to say to your question then about, Penrith. The Penrith model used to be staffed, I believe. I wasn't here then, but it was staffed. And now it's not, it's staffed where they just, the community midwives go in. And the low uptake, I've been told verbally, is because they can't stay overnight when they've given birth. So I think a lot of people have chosen not to do that, but that's just anecdotal conversations I've had. If we were to look at having to have a midwifery-led unit at Whitehaven, I have got a totally different staffing model in my head, and I'm happy to share this. It would be staffed with at least 2 qualified staff on duty. It would be an integrated model with a community midwife, and with maybe even looking at healthcare assistance, so there's that support there. We, like I say, it's really hard to know what the uptake would be of people having births there. And again, a lot of the big issues for women and midwives is the travel, is the distance to the consultant-led unit. So that's where we would do huge, which we do now. Can I just say that we've already got guidelines in place for people for home birth and Penrith. They're already there. So everybody's risk assessed when they want to book, when they're booking with a midwife, the risk assessed throughout the pregnancy, the risk assessed the minute they come in at the phone call, from when they get into the unit. So if there's anything at all that's not going to fit the criteria, they would be transferred pretty much straight away, or maybe even asked to go straight to Carlisle rather than going to Whitehaven first. Yeah, it's not ideal. I think what Rod's just said, in an ideal world, I came here in January with the premise of having 2 consultant-led units and 2 alongside midwifery-led units. That was my brief when I got the job. What's happened since is the sustainability of the paediatric service, and I think the risk, which I'm going to come to the gentleman over here in a minute, is if we know women have got risk factors, we have to make sure they're in the right place and for the safe care. Nobody goes to work to make, cause any problems. And if we haven't got the paediatric support, I don't want women in labour at a unit where there isn't the paediatric or obstetric support. The other thing I just want to touch on, just to answer your question before I move on to the next one, was about the low-risk elective cesarean. Now, again, I've only been here a short time. I have had an opinion on this, that there's no such thing as a low-risk elective cesarean section in a midwifery-led unit. If they were going to be offering a service like that down the line, it definitely wouldn't be within the midwifery-led unit. I want to make that very clear. That does not fit the criteria. It would be a separate unit that would offer that service within West Cumberland Hospital. It definitely wouldn't be within a midwifery-led unit. And does that answer your question?
Yeah. I think the gentleman was asking
I want to just come to this gentleman now. First of all, I just want to really say I'm really sorry to hear your story. I always get quite emotional talking about when things happen like this, because I've been a midwife for 27 of my 36 years in the service, and unfortunately it's not all happiness for us and for women and families. I'm really pleased to hear you got good care, and even in sad circumstances, and I know you just said you were, was it your daughter? Sorry, I missed that. Was it daughter? Daughter's son, yeah, it's your daughter, yeah. Did go to Carlisle for a second baby, and you did get good care. But I do appreciate what you're saying about having the consultant-led service at West Cumberland, and I do understand that. I really, really do. And I do understand what everybody's concerns are regarding not having the consultant-led services on site.
Okay, thank you. There was a very general question about Cumbria as a diamond. Why can't we have the location of the hospital at West Cumberland? It wasn't. I don't think it's you. I think it was more for the panel to think about in terms of, on a geographic basis, why don't we just invest in that hospital?
Oh, right. So essentially, the option of moving everything to Whitehaven was considered. It is a challenging geography and also population distribution, because hospitals tend to grow up around population distributions, and you've got two almost equal populations, if you look at it. I mean, we can argue where the boundaries sit and things, and they can be redrawn. On balance, the option of moving everything on the acute side to Whitehaven, in other words, basically reprofiling the hospitals round the other way, you would have to do a considerable amount of building work to house all of the acute services, the cardiology back in Whitehaven. And I think the other thing about some of that is also the if you like, the maldistribution when it would then occur with some of your specialized equipment and some of the specialists who would have to be attached to that move as well. But it was certainly considered as part of all of the options in the success regime. And it is an unfortunate accident of geography, and remote and rural populations do suffer this problem often equally. If I was to start with a clean slate and money was no object, we probably would build something completely new, somewhere west biased. So, you know, you'd move it out of Carlisle, but then of course you've got all the transport costs which come from that way round. So, but that's something we can't achieve or afford.
Okay. There was two ladies at the back that I must admit I've now lost exactly which two ladies. There was a gentleman here, and then I can see this lady down here waving at me, and that gentleman. So if we can do the two ladies at the back, that gentleman there, and then we'll come back round this way.
Good evening, everybody. I would like to make three specific points. One, I have recently come out of Cumberland Hospital having broken my leg. Whilst I was there were several people moved for convalescent reasons from the Cumberland Hospital down to Whitehaven by ambulance so that they could clear the beds. Now, these people should have been dispersed round the local smaller hospitals where they could have nursing care and the relatives would make an easy journey to visit them, instead of taking up beds in the other major hospital. Secondly, carrying on from there was one lady in the ward who'd been round for 7 hospitals in 14 months. She just couldn't live by herself. Now, she could have been catered for quite comfortably in one of the smaller hospitals. If we were living on the northeast, there's at least 5 major hospitals within the same distance of Whitehaven and Carlisle. That is not including Hexham or the new £9 million at Billingham, I think it is called, which is just 3-4 miles from Wansbeck Hospital over there. Anybody with major things like back or eyes or anything else have to travel from the West Cumbria over to the northeast, some 2 hours journey. In the northeast, they were considering closing a maternity unit. And there was a hue and cry because the people locally would have to travel 7 miles. Thirdly, with the cost of the finances of the NHS, am I right in what I've heard that all these modern hospitals, or the upgrading of hospitals, are done by outside forces, and that most of the NHS money that should be going to the medical care is actually going in rent for the hospitals? Thank you.
Okay. There was a gentleman here. Oh, sorry, there was another lady at the back. I think there was two of you at one stage. Are you happy with what you've heard, or you don't look like a lady? Have a quick question, then, and then we'll come to this gentleman here.
Sorry, I'm not a lady. I'm Dan Barkley, one of the GPs at the surgery here in Maryport. Oh, yeah. That's it. With a slight beard as well. But, yeah, it's all pretty scary, this really, isn't it? We've got an NHS which is chronically underfunded with threats of, well, possible threats of privatisation from the Tory government, potentially. We've got an acute trust which is doing its absolute best, but unfortunately is still very, very reliant on locums, basically due to the national recruitment crisis, which is obviously hitting us harder because with being a rural area, a lot of people don't really think about applying for a job here. And then if you go sort of a bit deeper into our own communities, primary care, I mean, there's recruitment issues in general practice all over the county. Locally, we're in the unfortunate position of our surgery of having about £200,000 taken off our budget, which essentially in real terms is about 2.5 doctors. And when that starts to bite, that's going to obviously be pretty scary. But there's a bit of a glimmer of hope, I feel, to be honest with you. And this is where I'm coming on to my question, which is really to everybody here, which is there's a couple of times this evening that something quite exciting has been mentioned, which is this idea of the Maryport Alliance. And this is a very new idea. It's basically the idea of trying to bring together quite a few different groups. It's trying to bring together community groups, so that's Maryport Smile, this is Save Our Beds, it's the Ewan Trust. It's also got a lot of support from John Howarth, who's obviously up at the front speaking as well, and it's got support from us here at the GP surgery as well. And this is basically to do with the fact that we've been told that we've got 2 weeks to come up with an alternative proposal regarding how we're going to sort out the issues that affect us here in Maryport. And I'm particularly talking about, obviously, the Cottage Hospital, which is one of the main reasons I would think that a lot of people have turned out here tonight, because of the fact that we all feel that we need beds here in our town for various purposes, palliative care purposes, rehab purposes. So one of the aims that we want to do through the Maryport Alliance is not just, is we want to try to keep beds here in Maryport, and we want to use beds in a clever way, which is making them really efficient. But we also want to turn this whole thing into something a bit more positive for the town. And what we'd really like to do is try to work together to bring more care into the town with the funding associated with that into the town, so that we can actually use this challenge that we're in at the moment to build something which we'll be really, really proud of in the future, and actually try to build the sort of health system that we'd all like to be treated in, the sort of health system that we'd all like to work in. So my question is, obviously these are all really grand ideas, but I'm asking, would you sort of stand with us on trying to do this as a group of community bodies all working together for all of us here in Maryport?
Sorry, is your question to the audience then, or is it to the panel?
Sorry, it's to the audience.
Okay.
Yeah.
Gentleman here, and then we'll come to the panel.
We've sat through a lot of these meetings, and I understand the problems you've got. But can I reverse things slightly? I mean, we get plenty of practice at putting our hands up on this side. Can I ask the panel a question? And I would like them to put their hands up if they agree with what I'm saying. Do you think it's safe for pregnant women to travel 50 miles through night on the motor road, one of the worst roads in this area? Do you think that is safe and an improvement for West Cumbria? Can you put your hands up if you think that's good?
Can we ask the panel to respond to the maternity question again in a second?
I'm asking the panel to vote.
I think you've spoken about the...
Sorry, we're putting our hands up. Yes.
Is there a whip on?
I personally have, this has split the clinical community, right? And I think we have to be honest about this. It's not black and white either way. Yeah, I understand all the arguments about transferring. I've had 4 children at West Cumberland Hospital, and I understand all the arguments. I understand all the clinical arguments, but I still have, I'm speaking personally now, there are many doctors who have reservations about this. There's many doctors who, on balance, have moved to thinking this is the right option, have reservations about it, and I'm really worried about potential risks, and have spent a lot of time working it through. So it isn't a yes/no thing. For a lot of the people here, I think they have weighed all the evidence and come down on this side. But for me, it's one of these things where actually this isn't a black and white. It's split the clinical community down the middle, this issue, and we can't deny that. There are doctors writing to the papers. There are many GPs who don't agree. So it isn't. I think it's difficult putting the people in the panel on, but we have to answer honestly, and I'm trying to be honest to you.
I'm going to answer your question.
I really do think it's fair that you want to know what we think. I think it's really fair that we ask you what you think. Now, I don't think it's safe to take pregnant women through night to Carlisle on a very poor road. I just don't think that, You might think differently, but I can guarantee you there's nobody sitting down here thinks it's safe. And the other question I want to ask, if you do away with beds in cottage hospitals, that might mean care in the community. Now, I'm on the county council. I can tell you this. We are not equipped to take care of a lot more of the aging population in this county. Our care workers got to a stage where they were putting people to bed, older people, putting people to bed at 6 o'clock. And they were putting them to bed at 6 o'clock because there are another 3 or 4 to put to bed after that. And that is not good enough. I understand the difficulty you're in. I have a bit of experience about the health. And let me say this about the health service. Most people in here would put their hands up and say, we get a good service. Most people, and can I just finish by saying this? We paid 30 million for the cycling team to win gold medals in the Olympics. It's paid for by the National Lottery. Well, I tell you this, if I had my way, the National Lottery would be paying for the National Health Service.
Okay, I think you asked a direct question of the panel, and I think they were halfway through kind of answering that. So do you want to go back to the maternity question that you had? Because I think Christine was going to answer.
Well, I'm going to give you a very honest answer because you asked, is it safe? I would prefer that nobody had to travel in labour. I would prefer that we had everything on site. But the reality is, if we haven't got the services for the specialisms, the peds, the anaesthetics, I prefer that women birth where it's safe. And I don't want women travelling down the A595 either. I don't. Like I said to you, I travelled in labour with my own baby, and it was about 45 minutes as well, and that's not pleasant. So I know what it's like. And yes, I would prefer they didn't have to. Honestly, I would. But I honestly don't want women birthing in a unit where I haven't got a paediatrician. If it's a complex problem or an anaesthetic problem, that worries me more as well. So, I mean, it's not ideal, and I have to say it has been a bone of contention with the discussions, hasn't it, with the transport.
Okay,
so I do acknowledge what you're saying. I really am acknowledging what you're saying.
The gentleman asked a subsidiary about kind of social care, and that adds to the question.
I can't
I think,
answer about
from
the
lady.
cottage hospital, sorry.
No, the lady at the back was asking, I think, about delayed transfers of care, and then she went on to talk about PFI. Stephen, is that one more for you? Delayed transfers of care and PFI was the question from the lady at the back.
Well,
not
actually, I think
connection
probably
between the two.
Rob will answer the query about the private financing of the hospitals, which is not perhaps as you would imagine in terms of the drain on resources. Can I just come back to the challenge that the gentleman put to us? And so from my perspective, from the CCG, the Clinical Commissioning Group, the whole point of being here listening to you is that the Clinical Commissioning Group has not decided anything. And it will genuinely, sir, it has not. It is really important that we listen to the concerns, and we will take a view at the end of the consultation process about the balance of risk. What is the riskiest option? Which is the safest of options, that neither of which are perfect? And it'll be listening to critically yours and the concerns of many, many, many hundreds of other people, thousands actually, by the end of the consultation process, and very importantly, the views of clinicians, the professionals, who will give us the expertise, the advice we need to make that judgment in the spring of next year.
Okay, do you want to just repeat that question, sir? Could you just repeat the question, sir?
Well, what I was saying is, we're on about closing beds down in Maryport. It isn't 6 or 7 years ago that we were going to build a new hospital in Maryport, brand new, after they built one in Cockermouth. Is that correct?
I was a clinical leader for the community hospitals for years and years and years, and I've been on the National Committee for Community Hospitals. I've been co-opted for about 8, 9, 10 years now. I led the campaign to keep them open in 2007 from the health side of things. I also worked in Cockermouth. Now, the money disappeared for all the community hospitals. It was conceived, this idea, and I fought very, very hard with many others to try and get some money to rebuild the community hospitals around Cumbria. We had a lot of support from Sue Page, who was the chief exec of the PC at the time. Then austerity hit, and all the money disappeared. We lost all the money for rebuilding our community hospitals. The only reason we got the one built in Cockermouth, because I was heavily involved in it, is because of the floods. So we can manage to persuade people, because we were working out of porter cabins. I worked clinically with my colleagues for 4 years out of porter cabins with diggers outside. It was awful. That's we played all the cards to get it. Now, if you ask me where I would prefer to build, it would be in places, and there was a point before which we didn't really address, is the issue about the deprived communities around on this coastal area. And we've got to be really careful that we design services that don't just make access to care much more difficult for people in really quite challenged communities. And we've heard about the transport issues here, and there's no, you could go use Cockermouth Hospital. There's no public transport, is there, between Maryport and Cockermouth? So so that's the story behind the community hospitals. A lot of us fought extraordinarily hard not to lose that money, and we're extremely disappointed. It was an opportunity missed, I think.
Just before we come to, there's a lady here who's been asking a question, but I know this lady's also asked on that one there. I think we're beginning to run kind of a bit short of time, so we need just to think about whether or not there's stuff that you haven't had an opportunity to kind of ask the panel yet. But just before we move on, there was a question about PFI and there was a question about delayed discharge.
Yes, and I just wanted to pick up something. Sorry, Andy, I will pick up on this business of transporting women, because I'd never got to the end of my answer. But first of all, PFI costs, they're met centrally, and there's no additional burden on the health service here. So that's a quirk of the PFI. So that essentially, it costs no more to have that PFI building. Now, Whitehaven wasn't a PFI, and similar arrangements exist. The money. So that's the first thing. Secondly, I just want to pick up on this business of, because I think it does need clarifying. It's not about a vote. I think John answered it very well. This is about, did we exercise our minds on the risks, looking at the evidence that's around the world from the point of view of distance and travel times and outcomes? Did we essentially pass this through the regional network and national leaders in terms of, was this too far apart to consider? These options emerged from the Royal College of Gynecologists report. So this was something which I know has been a vexed question around this area for many, many years. It is not an easy thing to answer. It is not a clinical yes-no binary thing. It's about balancing both the risks of the transport and the risks of our services just not existing because we haven't got the staff to staff them. So it is a balance of risks in that sense.
And I think, just finally, the delayed transfers of care.
Just very quickly, quite right. There's nothing to be gained from transferring pressures from one bit of the system to another. So from health to social care, or social care to health, or from the acute hospital to primary care, or vice versa. Because we're all in a difficult position, and social care in particular is in a really difficult position. Some great people, colleagues work in social care. The real answer is what we're doing in the Maryport Alliance. This sort of approach of working together in partnership will find better solutions than we do when we get into opposition. It doesn't work. The conversations, don't work in opposition. We have to be in partnership. And then we have a chance of solving some of the real issues that we've got and we're challenged with.
Okay, this lady's been very, very patient. I'm sorry to have kept you waiting. It might not get to you, sir, I'm afraid, because we're going to go up this side now.
Sit down, can I just want to say that, yes, it is dangerous to take pregnant women from Whitehaven to Carlisle. I used to be an ambulance driver, and I know what I'm talking about. I'm an ex-nurse, by the way, as well. But what I'm going to say is we're fighting for Whitehaven Hospital and Maryport Cottage Hospital. And what you haven't taken into account is the fact that there's a new facility being built for nuclear power for the West Cumbrian area. And this is going to employ hundreds of people, which means the other side of Whitehaven Hospital, it's got to be extended, not closed down or anything like that, because you've got to take into account all these extra people that's going to come into the area and all the travelling backwards and forwards to work. And Maryport Cottage Hospital should take more beds so that Whitehaven Hospital can be emptied when people are ready to move. You know, this is common sense, really. It's just finance, that's all it is. It's just finance.
Okay, thank you. The lady here has been waiting a while as well.
You're taking things away from us, and we need more, not less. We need more. And think about this new facility. All these people that are going to move into the area.
Thank you. This lady down here.
Hi, just a small question is, mainly how big do you think Carlisle Hospital is? Because as it stands, without any bed closures now, they are transferring people back from Carlisle to Whitehaven.
Okay, forgive me, I think there was another gentleman a bit further back. That gentleman there.
Sorry, Brian Money, GP, Maryport. First of all, very disappointing in the success regime that despite the protests and the campaigning of the Save Our Beds group, the document that came out, of course, had no option of keeping beds in Maryport. So you do suspect how much do they listen. But I think that what has happened is it's actually galvanized us as a community to actually look at how we're going to use our beds and our facilities in Maryport in the future. And I'd like to publicly thank John for helping us to start to produce this document. But my question at the end for the panel is this. We are going to spend a lot of time, a lot of emotional support in producing this document, looking at how our vision for the next 5 years that healthcare is going to be provided in Maryport. But what are the chances of support, and most importantly, is there any money?
Okay, so should we take those three questions? If the panel could consider, I think the three questions there. One is, what's the impact of new industry coming to the area? Has that been thought about? The second question was, how busy is Carlisle anyway, and kind of workload planning? And the third question was, will the work that the Alliance is doing be considered properly? So I don't know which one you want to go with first.
So I'll take a couple of those. The Carlisle site, there is a lot of work done through the Carlisle site that doesn't need to be in an acute facility such as Carlisle. So one of the big tasks we're performing at the moment, because nothing stands still, so what we're doing is essentially looking at changing things around, and particularly moving outpatient clinics and the like that can be moved off that site and delivered more locally. And it's part of the, if you like, the exciting bit about Whitehaven that was mentioned by John, but it tends to get lost in this whole consultation, that we can actually move surgery back, particularly with the advances in surgical techniques, so such things become low risk. So that's the first thing. So there is some work going on to reduce, if you like, the activity that doesn't need to be in the Carlisle site. That's the first thing, and focusing it on acute work. And the second thing is, all the modelling suggests that when the industries come in, and it's difficult to believe, they have a very small impact on health demand, because most of the health demand certainly is not in your young working population. I don't know whether John wants to comment on that, because he's more the epidemiologist in it.
It's a fantastic opportunity. I mean, it's a infrastructure build bigger than the Olympics, isn't it? It's huge. I think it's right technically about the amount of demand on the health service, but there is also the how West Cumbria works together as a system and a community, and a lot of these things are interdependent, industry and health, and how we spend the money and where we spend the money. So I think it's a real, and I think it was one of the arguments made for the new West Cumberland Hospital when the commitment was for it to be built there, to actually have a proper hospital, real good hospital, close to all the nuclear facilities that are developing. Perhaps I could pick up on Dr. Money's point, and I think the question is the proposal we're working on together, and it's very difficult to balance all these different things, the finance, the staffing, but essentially what we need to do, I'll go back to what I said right at the beginning, 29,526 journeys out of Maryport every year for healthcare, mostly heading up to the acute trust, a lot of which could be brought back to be delivered locally. And then you free up our acute trust, the facilities in the acute trust, to do the things that it really needs to do, and it's not just stacked up and blocked with beds all the time. So the essence of the model is to bring more and more care, and the amount of work this lady at the front mentioned about doing more things in the hospital and having more people treated. So the model that we're developing is actually having it much more active in managing people. Not all in beds, perhaps some in beds, but more ambulatory assessments as well of frailty and so on. So I think the question for the CCG, who are formally leading this consultation, is would this counter-proposal from the Alliance be, again, formally considered as an option with it balanced against the other options.
And so, as I already answered the lady at the front, we would take that proposal very seriously and we would seriously consider it, yes. It doesn't mean to say it's a blank check to introduce the changes that you propose, but as you've said, it's a wonderful opportunity for the community to come up with solutions that we may not yet have thought of, very likely haven't thought of. And we would very much welcome that, and you have my word, we will take it very, very seriously and it will be formally considered.
And just on that basis, I know this lady was saying to me before the start, there is a way in which people can join up to the Alliance. So, did you want to say something quickly?
Hi, I'm Anne-Marie, and I work with Kate at Unrig Local Trust. On your seats tonight, there is some bits of paper that tell you a bit more about the Alliance and how you can be involved. There's a public meeting on the 16th of November at the community centre where details of the proposal that we will put to the success regime will be there for you to understand, to have explained to you, and to have your say on the document. So we really would welcome you to come down and get involved in that document, but also as a way of continuing the communication with the Alliance. There's 3 ways that you can get in touch with us. There's text number, there's an email address, and there's area on the paper for you to fill in tonight. If you don't have a pen with you, we have some at the front. Please leave your details, text us or email us, and we will keep you informed and in the loop and engaged in what's going on. Please help us to get this document and make it a success.
Ladies and gentlemen, can I just check if there are any areas that John introduced when he did the presentation at the beginning of the evening about changes to services that you don't think we've had a chance to talk about? There's a lady, and I shut a gentleman down before. We did start a little bit late, and I'm sure if there are burning questions, we're more than happy to take those. But I just want to check that there's nothing, a big issue that we haven't covered that people feel we should have done so. There's a big issue, right? Can the gentleman have the microphone then, and then and we'll come to you as well straight after this gentleman, all right? And then we'll stop there.
There is one big issue, and that is that you group here have so much influence. Now then, if you move the facilities which are in Whitehaven and which are in our community further afield, there will be a spike, an immediate spike in mortalities. Childhood, prenatal, postnatal deaths. That's how it'll translate. You know, in terms of statistics, that's the way it goes. Remove the facilities away, and we are affected directly, and it'll translate into child deaths. It's as simple as that. There's one other point, which I'm privy to have an insight into it, because in the process of winding down Whitehaven, you built up the facilities at Carlisle. The surgeons, the specialists, moved up there, so you closed down another department. As a consequence, that department, I can't name it, is administered from Carlisle. A nurse I know who worked at Whitehaven, part of her routine was to go to Eskdale, to go to Millham, take the afternoon, 200-mile round trip. That has to be done from Carlisle. Because they can't recruit locally, it's going to be young ladies, young nurses from Carlisle. You're not going to get our young girls going into nursing, having to travel up, back shift, morning shift. Because that department closed down, it looks as though there's a spike. It might not show statistically. There is a spike that I can discern in the number of mortalities from a particular type of cancer. You move the facilities, and that's what happens. Repeat it in another department, close it down, move it away, and there'll be a spike in mortalities. It's a poor path to take. a poor reasoning to say we're going to focus centre of excellence further away. It doesn't work. It'll translate into greater mortality, greater illness, and then we're going to have to start paying for it. That is the wrong tack to take.
Okay, thank you. And I think finally the lady here was going to ask a further question. Just this lady here was going to ask a final question. Right here with the duffel coat on. Rod, are you all right to take a question? Rod, will you be able to take a question about the kind of workforce planning and recruitment and the redesign of services in a second? Sorry.
Sorry, I'm hogging the microphone again. I just wanted to ask, there was mention about the sustainability of a consultant-led unit, and this may not happen because of the lack of paediatric staffing, which I 100% agree. We do obviously need full support from not only midwives, consultant obstetricians, but also from paediatrics. They are key as well, which sometimes some people forget. However, if Whitehaven can't recruit paediatrics, and we are going to send 800 plus women to Carlisle, where do the paediatrics come from then? Because we're all one trust. So if there's no paediatrics in Whitehaven, there's no paediatrics in Carlisle either. And we'd have to use locums. So if we were using locums in Carlisle, why is that fair? Why can't we just continue using locums in Whitehaven then? How is this problem solved? Where do the paediatricians come from?
Sir, can I just check that it sounds like that's a similar question about kind of workforce and the impact on outcomes when you change workforce. Are you happy if they take that question together?
Right. So without knowing about the specifics of the service that was moved, one of the things we do monitor very closely, because it is a key statistic, but statistics are statistics. If we're moving services around, we do it for reasons, which we've tried to explain tonight, but also we would be monitoring any impact on mortality. Mortality is a very crude index, and I have to say that it's one I don't particularly like, because actually we should be avoiding mortality. So this is about actually good clinical outcomes, high quality outcomes, and that was the reason why we are in special measures, and that is the reason why we're trying to get ourselves out of there, because one of the reasons recruitment is so bad in this area, and I'm repeatedly asked this by young consultants who want to move here, is why are you in special measures? I don't want to come to a place that sounds like that. And like it or not, it's a negative recruitment feature. So one of the intense activities we're trying to do at the moment is get ourselves out of special measures, which was imposed in part because our mortality figures in this area were so high. It's a complex discussion, and I'm happy to engage with it afterwards if you like. But we would monitor any impact, and I'm really more interested in other quality measures, and there's a lot of them with each type of specifics like cancer and the like. Now, do you want? No. The pediatric argument is, again, a very complex one, but it's simply put. There is a national and international shortage of pediatricians. If I offer a consultant pediatrician, a young person, remember that they're coming out wanting to work still with quite a lot of support, in the sense that they're working within a collegial group, that they want to join a bigger department, certainly with good work-life balances, and that means in this country something like a 1 in 10 roster. If we run 2 1 in 5 rosters, by that I mean they're on call every 5th night. So we can have 10 consultants in Carlisle working on a 1 in 10, or we have to have 20 basically working across both sites. It doesn't matter whether, I mean, some of us do work across site, but it's the on-call that is the negative recruitment feature. So you have to have really minimum rosters of about 7 for most specialties, paediatrics, because they often do the paediatric intensive care is much more demanding overnight, and they tend to work on 1 in 10s. But it's more complexity to that. But that's a short answer.
John, I think you were going to.
I was just going to mention again the new medical school, and the new medical school campus is at Whitehaven. We've never had a medical school in Cumbria. It's very exciting. It's one of the most exciting times in my career. The ideas we have there, if we can get the UK students to come and recruit them locally, and then recruit them locally, train them locally, and then keep them locally. That's how most places sustain the medical workforce, and we've never had that in Cumbria. So that's a positive thing that's developed through UCLan, University of Central Lancashire. And we launched, I think it was a couple of weeks ago, the first scholarship. It's called the Kate Granger Scholarship, free to pay for somebody, a Cumbrian student, to go through the whole of medical school with a lot of support on the fees and accommodation and so on, which was part funded by North Cumbria yourselves, wasn't it? It was a joint initiative between North Cumbria Acute Trust and UCLan. So fantastic thing. So there are some positive things going on as well, but the recruitment thing, most people work where they were trained, in the end, and we've not been training doctors, and we're going to try and do something about that.
Okay, ladies and gentlemen, we've kind of come to the end of the time that we said we would spend together, but I just want to double check again that we haven't missed a huge issue. There are a number more of these public meetings where people can go to. I think we're on number 7 or 17 or something like that, I can't remember. And the panel, you'll see them again at each one of those. So if there is something else that you need to ask and you can get to one of those, then that's another opportunity. And there is always the opportunity to complete the consultation either online or at the back. And we've got lots and lots of copies of the consultation document for you to take away tonight. If you are content to finish, I'll do that on your behalf. Thank you very much for coming. I hope you have a safe journey home. And as I say, thanks for coming.